I have no personal disclosures, but just like Dr. Orbach, there's really no FDA-approved treatment for pediatric ischemic stroke. You can divide ischemic disease in children into arterial ischemic disease, hemorrhagic stroke, venous thrombosis, and hypoxic ischemia. I will focus on arterial ischemic stroke, and some of the other things I'll just briefly refer to or will be covered in the other talks. As far as arterial ischemic stroke in children, it's actually a rare disease, except in neonates, which is actually rather common. The incidence is increasing over the years with better imaging, especially MR and MRA, and there's now more treatment for some of the predisposing conditions. The median age is 5 years, though the peak is in the first year of life. There's a male predominance for whatever reason, which is unknown, and there's also a predominance in African American population, even if you correct for sickle cell disease. As far as death, it's in the top 10 causes of death in children. There's neurologic deficits in 2/3, and there's a 90 to 30% later risk of recurrence. As far as risk factors, well, these are the risk factors in adults. Most of these do not apply or are not very prevalent in children. So there are other risk factors at work here. This is one of many types of classifications that you can have as far as the etiology of strokes in children. Problems with the vessels, emboli coming from other places, problems with blood and coagulation, idiopathic causes. Some of the differences, the incidence is overall less. People don't think about it. There's subtle or non-focal neurological manifestations, which leads to underdiagnosis and delay in diagnosis. And there are multiple risk factors and etiologies, so sometimes it's a confusing picture. There's very few randomized clinical trials in terms of treatment strategies, and TPA is still not approved in children. There's a trial called TIPS coming out in 2016 to determine the dose of TPA in children, but the results are not out yet. In sickle cell disease, however, the incidence approaches adult stroke. As far as diagnosis, it's not something that clinicians, physicians, or sometimes even radiologists are very attuned to. More than 50% of children with arterial ischemic stroke are diagnosed after 12 to 24 hours from the time of presentation. About 10% have had a TIA in the past, which nobody did anything about. And there's this general unawareness of pediatric stroke. You can have silent infarcts which do not manifest and just you see them on imaging. You can have perinatal arterial ischemic strokes, sickle cell disease, moya, which may present later after the stroke has progressed. It's customary to classify pediatric stroke into two groups: the perinatal strokes, which is mid to late second trimester till the end of the neonatal period, and childhood strokes after the first month of life. The perinatal strokes themselves can be classified into perinatal arterioischemic strokes, periventricular venous infarcts, which are areas of venous thrombosis or venous-related ischemia, mostly in the deep and periventricular white matter. And the third category is the presumed perinatal arterial ischemic stroke, or presumed perinatal ischemic stroke, which could be mostly arterial but sometimes venous as well. These are presumed perinatal strokes that present later in life, within the first year, within the first 2 years of life, but no one notices at the time of birth. Perinatal stroke is 10 times more common than in older children, and 25% of all arterial ischemic strokes occur in neonates. The reason for that is that there are a lot of perinatal factors, coagulopathies, but the bulk of the reasons is not known. Most of these will remain idiopathic. It's a difficult thing to diagnose. There's usually not a whole lot of focal neurological signs. Seizure is the most common presentation. They may have lethargy, so there may not be a very good focal neurologically sign to indicate that the child may have a stroke. Some people have invoked placental pathologies, but that has not been proven in many cases. The good thing is that the chance of recurrence in these kids is very low. So at our place, these patients get a workup initially at the time of the stroke diagnosis, but are really not followed as far as imaging later in life. This is a 4-day-old. There are bilateral areas on this T2 image of loss of gray-white differentiation, very extensive. You can see the DWI, and you can see that the vessels are not well seen bilaterally. The MCAs and ACAs are not very well seen. This is another child with a stroke on the right. If you look carefully, you can see the area of restricted diffusion going down the corticospinal tract. This is actually a very poor prognostic sign. This child will not do well as far as motor function in the left extremities. So this is a poor prognosis sign. Strokes can occur during the fetal life as well. This is a twin gestation, twin-twin transfusion syndrome, and you can see bilateral infarcts that have occurred. This is another fetal stroke, unilateral in this case. Sometimes they occur early. Most schizencephalies are thought to be as a result of an ischemic damage to the brain. So if they occur early, then the cleft gets lined with migrating gray matter and a schizencephalic cleft is formed. Sometimes it's much more severe. These are different patients with various degrees of severity of hydranencephaly as a result of ischemic damage earlier during gestation. Occasionally, you may be able to pick it up on diffusion imaging as well. So this is a twin gestation with, again, twin-twin transfusion. And in the recipient, you can see the area of restricted diffusion, which is an acute ischemia. Presumed perinatal arterial ischemic stroke is another entity which is also unfortunately not uncommon. That the neonate was born, everything was fine, was sent home, no manifestations until later in life. The parents noticed that there is preferential use of one side of the body, or there is spasticity on one side, and that leads to investigations, sometimes months afterwards, or maybe a year or two afterwards, and these are the presumed perinatal ischemic strokes. No one knows when they occur, but the presumption is, given the high incidence in the perinatal period, that's when these things occurred. This is a DTI sequence. You can see the atrophied cortical spinal tract on that side. Again, this will be a very poor prognostic sign in terms of recovering motor function. Many of these children will be labeled as congenital hemiplegic cerebral palsy. It's relatively common, 1 in 4,000 live births. Most of them are term rather than preterm, and most of them are, just over half are thought to be as a result of arterial ischemic stroke. Just a little thing I wanted to say about punctate white matter ischemic injury, maybe not necessarily an arterial territory ischemic stroke, but in term patients, not necessarily preterm patients, especially those with congenital heart disease, sometimes you see these multiple foci of T1 hyperintensity. Some of them have restricted diffusion, some of them may have susceptibility, but most will not have restricted diffusion or susceptibility, and these are the punctate white matter ischemic injuries. Some people call them PVL, some people don't, but is very commonly seen in complex congenital heart disease. The reason for that is that there's multiple factors. One of them is that the periventricular and deep white matter, as shown in this whole brain perfusion, this is a coronal, you can see that the white matter, the deep white matter, has very low perfusion. So you essentially have an internal MCA territory watershed. And we looked at these patients and we looked at the brain maturation and using a scoring system, and we showed that they're actually, while they're term, their brains are immature by about a month or so. So it's probably a combination of factors, both the relative lower perfusion in the deep white matter along with selective vulnerability of the oligodendrocyte precursors that, just like the preterm babies, may result in these kinds of injuries. This is a patient that was referred to us for, it's a neonate, first week of life with bilateral temporal strokes. So we see these areas of restricted diffusion on ADC maps. It's low signal, but if you look carefully, there's some edema in those areas, and there is actually some superficial blood in these areas. And our esteemed moderator here described these about a decade ago, spontaneous superficial parenchymal leptomeningeal hemorrhage in term neonates. And there are essentially areas of subpeel and subarachnoid hemorrhage, maybe some parenchymal bleeds as well. These are a few other examples in 2 other patients that you have the subpeel and maybe subarachnoid hemorrhage. This is bilateral here. There's some edema in the adjacent parenchyma and maybe some restricted diffusion as well. And these are generally thought to be traumatic, maybe some contribution from venous ischemia as well. So this is a 10-year-old with typical stroke, acute right-sided weakness. You see the dense MCA sign, you see the cutoff in the MCA, you see the restricted diffusion. On SWI, you can sometimes see the clot, the cutoff on the MRA, and if you do SWI and ASL, there's a variable pattern depending on how the vessels have recanalized and whether you have hypo, iso, or hyperperfusion. Usually it's a mixed pattern. Sometimes you have areas of luxury perfusion mixed in with areas of hypoperfusion. Same with the SWI, that depending on the perfusion in those areas, even if the vessels have recanalized, depending on the deoxyhemoglobin content, the SWI may show black veins or show areas that the veins have diminished. The stroke neurologists use sometimes a different terminology that we may use. When I go to our weekly stroke conference, sometimes there is maybe some difference in the terms that we use. This is a set of terminology that has been proposed as far as the reasons for arterial ischemia in children, called the cascade criteria. It's a broad classification of what can be wrong with the vessels. So small vessel arteriopathy, unilateral focal cerebral arteriopathy or FCA, bilateral cerebral arteriopathy, aortic cervical, cardioembolic, multiple, and other. Now each of these, or some of these, could be progressive, they could be stable, they could be reversible, and sometimes if you have one time point you can't tell. But each of these unilateral, bilateral, or aortic cervicals may progress, may be stable, or may get better. So this is a case of focal cerebral arteriopathy. You have this basal ganglia region infarct, you have this stenosis in the proximal MCA, and this is what the stroke neurologists will refer to as focal cerebral arteriopathy, or FCA. It's generally a loosely defined term. It's some irregularity and narrowing of the vessel, most commonly the proximal MCA. Some of them are transient, some of them are stable, some of them are progressive. You can have dissection, you can have FMD, post-varicella infections have been invoked, other infections have been invoked, large vessel vasculitis has been invoked, and this is the terminology that's used. This is an example of a progressive type of focal cerebral arteriopathy. The A1 segment looks fine initially, and over the course of a few months, it becomes progressively narrowed, and almost in number 4, you can't almost see it anymore. This is a another case that the patient presented with right-sided weakness. There is this focal narrowing in the distal ICA. Maybe there's some enhancement along the vessel wall, and within a week that the patient was going to go to angiography, it has opened up. So this would be considered a transient focal cerebral arteriopathy. Moving on to sickle cell disease, the risk of stroke is very high in sickle cell and approaches older adult stroke risk. The annual risk of initial stroke is 0.7% per year, but later on it increases. There's a large number of silent strokes in this population, and over time these silent strokes may lead to IQ decline and neurobehavioral issues as well. Transfusion regimens help those with silent strokes, and it's based on imaging. But obviously, you don't want to put a child on a chronic transfusion regimen, because transfusions have their complications as well. Most common area of involvement is similar to a Moya-Moya type distribution, distal ICA, proximal MCA, and ACA. Most of the silent infarcts are in the deep white matter, and if you look, you can see these concretions along the endothelial lining and endothelial proliferation in these vessels. This is a typical example. You have the ICA stenosis, watershed territory infarcts, and sometimes they lead to a lot of destruction over time. There was a trial that was published in 1999, the STOP trial, which they investigated sickle cell disease arteriopathy as evaluated using transcranial Doppler. And it was shown that those with abnormal velocities will benefit from chronic transfusion regimens. Actually, chronic transfusion regimens will decrease the chance of stroke to 1/10 in these patients with an abnormal TCD. But with normal ones, it really did not have that extent of an effect. And they used this criteria, less than 170 centimeters per second, 170 to 199, and greater than 200 was considered abnormal, and those were the ones that would benefit from transfusion, and those were the ones that sometimes they would go on and get further imaging, for example, with MRAs. Now, there's a problem with regular TCD. The STOP trial is based on regular TCD, but TCDI imaging has shown to be more accurate because of the angle correction, but it's not used very commonly because the original STOP trial criteria was used based on regular TCD and not TCDI imaging. So despite being more accurate, a lot of people don't use this. And this is yet another patient with sickle cell disease and bilateral, both chronic and new infarcts. Infections can cause ischemia in the brain as well. Meningitis can cause venous infarcts, and it can cause arterial infarcts as well. So this is a patient with florid meningitis with multifocal infarcts in the watershed territories. These are 3 different patients with bacterial meningitis, and you can see the scattered areas of infarct in the brain. This is a histopathological slide showing that the neutrophils are actually invading the arterial wall. This is a 4-year-old girl with TB meningitis. You can see the enhancement in the right MCA cistern, and a few weeks later, there was an infarct. You can see the stenosis and stretching of the MCA that has occurred as a result of this rampant TB infection. This is a 9-year-old with sinusitis with change of mental status. You can see the sinusitis here. Was imaged with MRI. You can see the abscesses in and around the cavernous sinuses, pus in the cavernous sinuses, and narrowing of the vessels. On MRA, there's actually this contrast-enhanced MRA. There's really no carotid flow to the brain, and this is essentially a brain on a stick just being fed by the basilar artery. It's interesting that many of these kids, despite the really bad vasculopathy and stenosis, they don't infarct as long as they have a good circle of Willis. Radiation vasculopathy is also a cause of brain ischemia in children. This is a patient that had whole brain radiation many, many years ago. You can see the characteristic findings of radiation damage to the brain. You see the calcifications, white matter changes, mineralization on MRI, and you can see the multifocal areas of narrowing in the brain as well. This is a patient that I followed when I was a fellow that had medulloblastoma, got radiated, was doing fine for about 10 years, and then would develop recurrent TIA symptoms. So this is the original CTA, which looks relatively fine, but then 20 months later had further bouts of TIA, got the CTA. Now you can see the multifocal stenoses, and then 9 months after that was really debilitated with these recurrent TIA events, and you can see the progression in the stenoses in the posterior circulation. Needless to say, we stopped doing CTAs on this patient, and this was also a case of radiation-induced vasculopathy, and there is an entity called radiation-accelerated atherosclerosis as well, that this could be one of those as well. This is an 8-year-old with new change in mental status. This is the initial MRI, and you can see the extensive white matter damage, extensive damage to the cortex bilaterally. You can see all these extensive collaterals in the basal ganglia and white matter, collaterals on FLAIR imaging, the FLAIR IV sign in the sulci, and this is a case of Moyamoya disease, very extensive, very severe. And this is the ASL imaging in this patient, which shows the higher perfusion you see in the basal ganglia because of all these collaterals there, but the parenchyma looks black. So actually I was talking to people yesterday, and they wanted me to talk about using ASL in Moyamoya disease. So I'm going to show some slides about the use of ASL here. So these areas are black, but does that mean there's really no perfusion there? This is a limitation of ASL that I will just briefly discuss. So this is how ASL is done generally. So you have the vessels, you do an echoplanar or spiral acquisition, and you get an image. Then you tag the vessels somewhere, usually in the neck, but it doesn't have to be. The tag could be in the head as well, depending on the pulse labeling scheme that you're using. Then the blood gets tagged, goes into the brain. Now you image with the tagged blood, and then you have a second set of images. Normally, if you look at the images, there's no difference because the change in signal as a result of the tag is in the order of 1 to 2 to 3%. So it's really not perceptible to the eye. But if you do a subtraction of these images, you'll get a subtracted image which is proportional to the tag that went from the neck into the brain, so it's proportional to cerebral blood flow. And you can get maps, you can quantify it, you can standardize it. So this is a normal ASL map. And there are some uses, obviously, for US ASL in cerebrovascular evaluation. This is actually a case from last week. This was an NF1 patient, first-time focal seizure. Dr. Vezina was talking about with screening for NF1, if it's a religion, some people do it, some people don't. At our place, it seems like there are very, very religious individuals there that scan everyone. But this one happened to have focal seizures in the left upper extremity. This was a routine scan. There was no MRA ordered. But on the ASL, we've been doing ASL routinely for the past 7 years. So I noticed this high signal in the vessels in the MCA branches, and the parenchyma was low. So that tells me the tag, which is dense, is still in the vessels, hasn't made it to the parenchyma yet. So there has to be a proximal stenosis. And on the coronal T2, yes, there was a stenosis there, and looking back, yes, there was some stenosis on the prior scan as well, which went unnoticed. So there is some utility. This is a rhabdomyosarcoma, just under the skull base, goes up through ovale into the cavernous sinus, and it's narrowing the vessels. And through multiple follow-up examinations, the ASL started to look like this. Again, you have this high signal in the vessels, which means there is a delay. There is a physiological delay in the transit, the arterial arrival time delay in getting there. And as this progressed, it led to a watershed infarct, a perfusional infarct, if you will. Now, there's a problem with ASL. The tag has a limited half-life. Just after a very short few seconds, the tag will vanish. It's a T1-based sequence. After a few seconds, the longitudinal relaxation will go back up, so the tag will vanish, the label will vanish into thin air. So if you tag in the neck, by the time it gets the parenchyma through collaterals or through stenoses, the tag is not there. Since you don't have tag, the brain will look black, and you're going to conclude, oh, there's no perfusion there. But we don't know that. This could be just a delay effect rather than hypoperfusion. Yes, having a very long delay is not normal, but there is a problem here in calculating perfusion. So this is what happens. Normally, you tag it, things go up very fast, and you get your scan. But if you have a delay, either through collaterals or stenoses, things go slow. So by the time they get to the brain, the tag no longer exists, and you will have a black brain. So ASL will grossly underestimate CBF in cases of prolonged arterial arrival time. So can we use this in moyamoya? Can we use this to decide when to do surgery? Well, in my book, if you have stenoses and you have an organ or brain damage, I think that's a redundant question or superfluous question. The damage is done, you probably need to do something about it. Same thing, you did the synangiosis and you want to know if the synangiosis worked, and you want to use ASL for that. Well, the tag is coming through these very long channel, slow collaterals. So the blackness that you see here in the brain, does that mean there's no perfusion? Or does it mean no, blood does get there, but it just gets there very late? So some food for thought. I don't think this technique is useful for assessing post-synangiosis efficacy. If you do need to do something for a preoperative evaluation, again, I would argue for most cases you won't, you could do something like this, cerebrovascular reactivity testing using BOLD. So you have your moyamoya, you have your stenosis. Now you want to know if it's physiologically significant or not, to do it for timing of surgery, or if your neurosurgeon needs some more data points or psychological support to go ahead with the surgery. You can do a baseline BOLD, then have a vasodilatory stimulation, whether it be Diamox, whether it be some standard hypercarbia, and repeat the BOLD, do the comparison, and see whether this abnormal area will respond or not. So this is another patient with moyamoya with low perfusion here, and while I was waiting to get synangiosis in the following week, developed an infarct. And we did the imaging using arterial wall imaging here with contrast, and we see that this segment shows arterial wall enhancement. Now, is this a superimposed mechanism? Is there an infection? We don't know. So what is the role of minor infections in pediatric stroke? Recently, in 2014, there was one group out of UCSF that looked at a cohort of 2.5 million children, found 102 children with arterial ischemic stroke, and they found that if there was an infectious visit to the doctor within 3 days before the stroke, there was a 12 times higher risk of having a stroke. Most of those were upper respiratory infections. Now, is it a prothrombotic endothelial injury? We don't know, but it seems that, yes, a normal upper respiratory infection, the common cold, is a risk factor for childhood arterial ischemic stroke. As far as treatment, well, there's really no FDA-approved treatment. The guidelines specifically say that thrombolytic therapy is not recommended for children with arterial ischemic stroke outside a clinical trial. I'm sure most of you institutions have had some older teenagers or some select patients that have gotten IV TPA or certainly other ones that have gotten IA TPA or mechanical thrombolysis, but there's really no good guideline. This is an example of a patient post-heart transplant on ECMO, sudden onset change in mental status, and right hemiplegia. You can see the obstruction here, had thrombolysis, the vessels have opened up, and this is the post-intervention scan. And now you see this area of high density. If you do these with dual source CT, you could actually get an iodine map and determine that this was not an actual hemorrhage, which is just contrast staining in the area of infarct. Prognosis, it is an important cause of death. There are a lot of neurological deficits, and there's a risk of recurrence. Long-term seizures and bleeding are important complications. About hemorrhagic transformation, the bad news is it occurs frequently. The good news is they're not very severe. And finally, stroke recurrence risk. After perinatal arterioischemic stroke, it's actually very low. 19% after childhood ischemic stroke. But here, the main determinant is whether there is a vasculopathy or not. If there's no vasculopathy, in a very large cohort, they found no recurrence. But if there was a vasculopathy, more than half had a recurrence down the road. So, in conclusion, pediatric stroke is not rare, especially in certain populations. It's frequently underdiagnosed and often different from adult stroke. There must be high index of suspicion. We need to do the appropriate imaging, especially vascular imaging, and based on the vascular imaging, the patients need to be risk stratified and treated accordingly.